Hello, this is Robert Lee, and this is a brief video on the randomized trials of radical prostatectomy in prostate cancer. Brief agenda: we'll look at 3 studies. 2 compare radical prostatectomy with observation, and the third compares radical prostatectomy against active surveillance and radiotherapy as well. So, surgery versus observation first. The first trial to be considered is SPCG4. It's been published on multiple occasions. Includes almost 700 men diagnosed with prostate cancer between 1989 and 1999. The trial was performed in Scandinavia, where PSA screening was low. Eligibility criteria are listed, and notice that the enrolled population had a median PSA of 13, and the vast majority had palpable disease. Patients were randomized to radical prostatectomy or watchful waiting. If they were randomized to radical prostatectomy, lymph node dissection was performed, and if negative, then proceeded with radical prostatectomy. If recurrence developed after radical prostatectomy, then androgen deprivation therapy was allowed. The watchful waiting arm allowed for androgen deprivation if metastatic disease was noted, and also allowed for TURP for local symptoms. Later in the trial, after 2003, androgen deprivation therapy could be given only for a rising PSA in the absence of evidence of metastatic disease. Here are the results after 23 years of follow-up. All-cause mortality, prostate cancer mortality, and distant metastasis. All of the endpoints were improved with radical prostatectomy. That is, mortality, all-cause mortality was less. The absolute risk reduction you can see in this column here, the number needed to treat here, and the relative risk in the final column. Remember, this is a Scandinavian cohort with, for the most part, non-screen detected prostate cancer. The second trial of radical prostatectomy versus observation was done in the United States. It's a VA consortium. Again, about 700 men. The characteristics of the enrolled patients is what you see. It's quite different than you saw in the Scandinavian trial. The median PSA is 7.8, which is about half what it was in the Scandinavian trial. Half of the patients had non-palpable disease, and more than half of the patients had Gleason 6 or less. So this is a very different population, lower risk from the prostate cancer perspective. I should also point out that it was originally designed to enroll 2,000 men, but after troubles with accrual, they rewrote the hypothesis and looked at 731 men. The most recent update of this trial was published in European Urology in 2020. And for the first time, overall mortality was found to be statistically superior in patients treated with radical prostatectomy. The absolute risk reduction you see there, approximately 6 percentage points. The number needed to treat is 18. Now, one can argue that the magnitude of the benefit is limited. Nevertheless, more evidence that in a very low-risk population, radical prostatectomy does influence overall mortality. This slide compares the SPCG study with a number needed to treat of 8 to the PIVOT study with a number needed to treat of 18. Around 700 patients in each study, long follow-up in each, similar ages but different disease, much higher PSA in the SPCG study. If you look at the number of overall deaths in the SPCG study, 550, the PIVOT study 460. You can see that when you look at the percentage of deaths related to prostate cancer in the SPCG study, a third of men died of prostate cancer, which is very different than the PIVOT trial, in which only 15% of men died of prostate cancer. So you have a different natural history playing out here, much more aggressive disease on SPCG compared to PIVOT. Which now brings us to the PROTECT trial, which published now 4 years ago in the New England Journal. It's a randomized comparison of more than 2,000 men to radical prostatectomy, radiation therapy with short-term hormonal therapy, or active surveillance. So this is different. This is comparing definitive treatment to active surveillance rather than watchful waiting or observation. And there are 2 treatment arms, surgery and radiation. A brief glance at the demographic and clinical characteristics of the patient enrolled in this study will find an even earlier population as far as prostate cancer is concerned. 3/4 of the men had Gleason 6 cancer, and 90% of men had a PSA of less than 10. The median PSA is less than 5. Compare this to the PIVOT study, where the median PSA was 7.8, or the SPCG study, where the median PSA is 13. So this is a very early disease, very early in the disease process, and this is mostly a screen-detected population, analogous to the more contemporary series. Now, the primary endpoint of the PROTECT trial is prostate cancer-specific survival, which is what motivated the sample size. Now, with this very low-risk population, you can expect very few deaths, and in fact, only 17 have been observed when the paper was originally published. To me, this is remarkably underpowered. If you have 17 events across 3 arms, it's very difficult to say whether, in fact, any of the treatments are different from one another. If you look at disease progression, it's clear that the treatments, be it surgery or radiotherapy plus short-term hormonal therapy, improve freedom from disease progression. And if the question is asked, does definitive treatment change the natural history? The answer is yes, although there's clearly no evidence of a survival benefit in the first decade. The other part of the PROTECT trial that I think is the most influential is actually looking at patient-reported outcomes after treatment or active monitoring. These were validated questionnaires. Bottom line is that surgery had the greatest negative effect on sexual function and urinary incontinence. The radiotherapy group had more short-term bowel dysfunction, but that generally recovered. So if we are evidence-based practitioners, we take the best research evidence, which as it relates to radical prostatectomy I've presented to you, and integrate that with patient values. Remember that if we want to integrate patient values, we need to ask the patients how they feel about the disease. And this is one example taken from a primary care population. 260 men were surveyed, asking them how long they expected to live with or without the treatment. You can see that in this population, more than 30% of men expected to die within 5 years without treatment, which is a gross exaggeration of that. In fact, in low-risk disease, the likelihood of dying in the first decade without treatment is probably 1%. The other thing to notice is that the treatment effect, that is the benefit of treatment, is dramatically overestimated by patients. So not only do they think the disease is worse than it is, they think the treatment effect is actually much greater than it is. So here are the take-home points with radical prostatectomy. It clearly changes the natural history of the disease, but in men with low-risk prostate cancer who are older, in fact, there's no evidence of a benefit. Radical prostatectomy does have urinary and sexual morbidity, which improve with time, but compared to radiation therapy and hormonal therapy, or active monitoring for that matter, there's more urinary and sexual morbidity. As I've already said, there is no treatment effect observed in older men with low-risk disease, which is why those are men who preferentially should be treated with active surveillance. And patients overestimate the treatment effect. This is something that as physicians we can do a better job providing context for our patients so that they make good decisions for them. Here are the resources, the papers that I've already alluded to, and I thank you.